Good afternoon, and thanks for the introduction. I'm Roberta Bujay, and I'm a specialist trainee in obstetrics and gynecology working in Newcastle in the UK. And I'm here to discuss with you our preliminary results of mesh complication surgery from my centre, which is a large tertiary centre in the UK. We have no declarations of interest. So in the UK, back in July 2018, we've had a pause in the use of synthetic mesh or tape, and for this reason, it has become quite an NHS priority to provide mesh complication services. The aim of our study was to assess the patient-reported outcomes from the preliminary set series of women that were referred to our unit with mesh complications. We conducted a retrospective study over a 2.5-year period, including the 34 patients that were referred to our unit, looked into the indications for the surgery, the type of surgery that they've had undertaken, complications, and the post-op follow-up. Then apart from that, an independent follow-up review was undertaken. Follow-up was done in two ways. First part was assessing the patient-reported outcome measures according to the 6 domains listed, and each patient was asked to actually rank according to the 7-point Likert scale with regards to each of the 6 domains. The second part of the follow-up was actually assessing the global outcomes. So the patients were asked 3 separate questions. The first one was, how likely are they to recommend the surgery to a friend or a family member, that is, the mesh complication surgery? Also, with hindsight, knowing the outcome that they have from the mesh complication surgery, would they still have undergone the same procedure? The third question was, how do they rate the improvement in their overall well-being following the mesh complication surgery? Each patient ranked between 0 to 10, 10 being the most highly satisfied. The median length of time following the original mesh surgery was 6 years, and as this graph shows, the main indication for surgery for most of our patients was actually pain, with 82% of our patients reporting pain as one of their main indicators. Out of the 34 women undergoing surgery, more than a third of them had actually a complete removal, 12 having a partial removal and 8 having a repair of a vaginal erosion. Out of the 34 patients, 41% had a concomitant anti-incontinence procedure at the same time of having the mesh removal surgery, out of which 62% opted for an autologous facial sling insertion. The post-op assessment, as said earlier, was undertaken independently of the operating surgeon, increasing the validity of the study. 31 patients provided outcome data out of the 34, and the mean follow-up time was 7.8 months. Looking at the patient-reported outcome measures, since major indication was pain, 45% of the patients reported a significant improvement in the pain. With regards to the other 5 domains, however, most of our patients reported no change. Extrapolating a bit further into urinary incontinence, apart from 48% reporting no change, we did have 39% of our patients reporting that their urinary incontinence had actually become worse. However, looking at the global assessments, for each of the questions, most of our patients actually reported an average of 7 or above. This means that despite of the patient-reported outcome measures, most of our patients seem to be actually satisfied with the outcome that they've had from the surgery. There was also no significant difference from whether the patient had a complete removal or a partial removal of the mesh. In conclusion, the majority of our patients did report a significant improvement in the pain. Also, there has been a significant average improvement in the overall well-being of our patients, and from this, despite the limited number of patients, we can say that there has been satisfactory short-term surgical outcomes being achievable in this relatively new subspecialty in urogynecology. Limitations of the study are obviously a short duration of follow-up, and also we did have a preponderance of TVTs, hence making it quite difficult to extrapolate this to mesh removal surgery in general. Thank you for listening.
Thank you very much. I have a question.
Yes?
You stated that 13% of the patients had still 13% of them had still worsening of their pain post-operatively.
Yes.
Could you see if they were those who did a concomitant
No, I did not look into that. The one thing that I did notice is that these patients tended to have other conditions, something like fibromyalgia or chronic pain syndrome, that probably actually results in the reason why they still would have the pain, because we can't cure it by just removing the mesh. So that was one of the things that I did notice, but sorry, I did not take into account that they've had facial sting insertion at the same time. Thanks.
Yes. Alex
hi.
Berger, San Diego, California. Excellent study. Thank you for presenting it
Thank
today. I found it really interesting, the willingness or propensity to recommend the procedure in this group of patients that have had a complication that required a reoperation. I'd be curious your thoughts on why that is, why those rates were 7, 8, 9 out of 10. And then secondly, if you would consider looking at a control group of patients who had the same types of procedures and didn't have a reoperation, and what their willingness or likelihood to re-recommend.
That's definitely a really good recommendation. The other thing about checking the global outcome, I do think when we ask about pain, it's a real big issue with perception. So someone can say, oh, I've had a lot of pain before, but now I'm much better. Another thing that I did notice was most of our women were actually quite of a bit of an older age group. So it could be if you have a younger patient, they might be more interested in not having urinary incontinence, whereas an older patient might be more interested in actually not having pain anymore, or the fact that they can actually go to do some shopping without needing a wheelchair, which is something that these women were actually saying over the phone, because I was actually the one doing the interviews for most of them. So that is what I can gather why they would actually recommend having the surgery, and why they actually feel better despite what they've actually reported with the measures.
Yeah. In terms of surgery, you can actually get a placebo effect of probably about 6 months. If you excluded those patients who only had a 6-month follow-up, do you think that there was a difference? Do you think that removing the mesh made a difference? And did it make a difference as to whether it was a more complete removal as opposed to a partial removal?
No, so there was no difference between whether they've had a complete removal or a partial removal, that's for sure. With regards to longer follow-up time, I think we should really check on them, and with regards to a longer follow-up time, because that is actually one of the limitations of the study, which is a really, really short follow-up time. So yes, I do agree. It will make a bit of a difference, definitely. Okay, thank you. Thanks.